Okay, so we've looked at a lot of different um, drug classes that can reduce or restrict the immune response to demonstrate their usefulness in immunosuppression, obviously, as well as some of the hematologic and solid tumor malignancies. And so I'm just going to kind of go over some of the basic concepts. And so we can we can classify these drugs through a whole host of classification schemes. It really depends on who you read and how they want to do it. So I've kind of portrayed these drugs in two or three of the more popularly cited classification schemes. Um, Drugs that can inhibit cytokine production and activity or function are listed here. Anti-metabolite drugs listed here. Of course, antibodies, which would, we're going to presume for the most part, almost all of them are monoclonal. And of course, steroids, which just, keep coming up in several different disease states. It's one way of looking at them. You can also say, here's the drug class and the site of action, or, the individual drug. Um, and there's going to be some overlap. And if, of course, if you start cross-referencing some of these lists, certain drugs can be on other lists. For example, fingolimod is really not an anti-metabolitic drug, but it kind of fits in here in terms of, kind of how it works. It's really one of the few drugs that actually sequesters immune cells. Antibodies all have a similar mechanism of action in terms of inducing ADC, C, and CDC, but their molecular target is different. So there can be an antibody against a cytokine or a chemokine. There can be an antibody against a specific T cell or B cell marker. Um, there can be non-specific antibodies to just really any type of thymocyte that could potentially exist. So there's a whole different classification scheme it's not really clear cut, which is why students traditionally have a really hard time with immunosuppression. Okay. Here's a nice kind of summary diagram looking at the process of going from antigen through the T cell response that's dependent upon some key pro-inflammatory cytokines to cell proliferation. And of course, when we talk about cell proliferation, we're really referring to proliferation of T lymphocytes. And so you can here's a list or a couple of examples of drugs that specifically target or inhibit a specific process, the official mechanism of action, as well as some of the more commonly encountered adverse effects. A lot of these adverse effects are not um, commonsensical, and so you just kind of have to memorize some of the few that are listed. This is kind of a nice summary chart looking at the specific drug listed here on top, as well as what its molecular or cell target is. And so there's a whole bunch of different ways of looking at this stuff. Okay, so what are some examples of immunosuppressive regimens? We haven't really talked about, how to use these drugs. And I think, really the key concept here is that this is a pretty standard or pretty typical example of an immunosuppression type regimen. And this really, conceptually mirrors what's going on in terms of treating liquid and solid tumors as well, is that in some cases, you've got short courses of one or two or even three co-administered drugs for a brief period of time, followed by longer courses of more targeted, specific drugs, and then really long courses of, you know, um, adjuvant type compounds. You can see heparin under continuous infusion, really to keep the vessel that you're injecting into patent. Um, you can see anti-metabolites being employed for long periods of time. And so this is pretty standard for immunosuppression. So the step type questions don't really refer to, you know, which single drug is best, because these patients aren't really on a single drug. They're on regimens. And we can't even ask you which regimen is best because the regimens change over time. Okay, and so here's an example of where we're kind of looking at clinical findings, where we're co-administering certain drugs for certain time periods, and we're looking at other markers to see, are we having the patient at a higher risk of developing COPD, for example. A lot of the side effects of some of these immunosuppression type drugs is to suppress the immune system so potently that really commonly encountered relatively non-fatal viruses and infections can all of a sudden become more problematic. And so you also kind of see that um, taken as well. This is kind of a nice timeline that kind of examines how you manage infection after and during organ transplant. And of course, there's tons of drug guides and so forth. So what are some of the targeted therapies that we could use for cancer? Um, Very similar to some of the immunosuppressive therapies where you've got your frontline drug, and then you've got your adjuvant. This is my background's ovarian cancer, so this is an example where you've got like chemotherapeutic regimen 1 plus Avastin for a period of time, chemotherapeutic regimen 1 or 2 plus Avastin, and so on and so forth. And so these, you're constantly kind of fluxing these drugs, 2 weeks on, 1 week off, 4 weeks on, 2 weeks off, that kind of thing. So it's really hard to write test questions that say which one's better because this is constantly changing and subject to the overall health of the patient. Avastin might be the best drug for them, but they just may not tolerate it. Likewise, doxorubicin could be the best classic chemotherapeutic agent under regimen 1 or 2, but again, they just may not be able to handle it. Okay. Likewise, this is just a nice example of some of the current FDA-approved statuses for some of these drugs and how they work, what their clinical disease presentation is going to look like. And you can see from the ovarian or from the solid tumor standpoint, you can see ovarian, breast, colorectal. A lot of these drugs are in various phases of evaluation, and this is a constantly moving target. So I know this was a lot of material, but we really kind of wanted to portray all these drugs relatively equally so that you know kind of how they work. It's our understanding that you're not going to be ordering or prescribing probably any of these drugs unless you become a hematologist, a oncologist, or a organ transplant specialist. But you've at least seen kind of a nice representation of the main classes, and you in general understand how they work. And that's really what we're going for this particular topic. We want to know about generalities, um, and what's the concept? Why do we immunosuppress? What are we suppressing? And what's the clinical outcome going to be to that immunosuppression? How long is the patient going to be on it? Is this one that's going to be used for induction to, basically, you know, severely and quickly inhibit the immune system? Or is this going to be a kind of a longer process where we're going to be specifically targeting a known receptor that has a definitive pathologic role in disease progression? So that's kind of the general take on it. I am available for questions. I'm sure there's going to be questions on this lecture because it is difficult conceptually. There's lots of different drug classes, lots of moving targets, and lots of immunology. Okay, so hopefully you've enjoyed at least some of it and you learned something.